So I am really happy to introduce Dr. Ruru Wang, who joined the Division of Gerontology and Geriatric Medicine as a clinical instructor after recently completing her fellowship in geriatrics and residency in internal medicine at the University of Washington. She has a background in global health research and worked on the global burden of disease study at the Institute for Health Metrics and Evaluation prior to medical school. She is passionate about understanding the why behind clinical practices and learning from her colleagues, and is going to present today on anemia in older adults. Welcome, Dr. Wang.
Thank you so much for the intro, Bob. Hello, everyone, and thank you for being here today for today's presentation. My name is Ruru Wang, and I'm currently a clinical instructor in the Division of Geriatrics at UW. I wear a number of different hats. I work partly in primary care here at the senior care clinic. I also work in the skilled nursing environment, both in the care of post-acute patients and long-term care patients. And I also spend part of my time on the geriatric consult team and on the inpatient side, taking care of older adults who've had a hip fracture, for example. I wanted to talk to you all about anemia today, just because this is really about the why. I see so many patients in my clinical practice who have anemia, and I've seen a lot of people have different approaches to it. And so this presentation today is just for me to kind of share what I have learned in my time and some of the why behind that. So this is my disclosure slide. I have no conflicts of interest to disclose. I do want to remark that I am not a hematologist, and I just wanted to share that this is my approach as an internist and as a geriatrician, but that more complex cases, I always enlist the help of my hematology colleagues. I hope that with today's talk that you're able to describe some of the implications, especially the geriatric syndromes that can be associated with anemia in older adults. I hope that you're able to come up with some of the most common etiologies of anemia in older adults. I hope that you're able to walk away with a framework that you can think about how to work up an older adult with anemia, and also a framework to be able to think about how we treat those with iron and B12 deficiency anemia. And so I just wanted to start off with a quiz question. I did not know this number before I actually was looking into this talk. And so I just wanted to put it out there. How common do we think anemia is in community dwelling adults over the age of 65? Do we think that it's 10%, 20%, 40%, or 60%? And this number really surprised me. So that number is actually 10%, which is far lower than I was initially expecting before giving this presentation. And so I just wanted to kind of mention that I think for me, I have a bit of a sick bias that I'm seeing a lot of patients in the skilled nursing facilities or in the hospital who have anemia. And so this to me is a little bit of a gut check to actually say, hey, anemia actually isn't that common in older adults who are community dwellers. And so, hey, this is an abnormality that I need to think about. And so just to go over the different numbers in different settings. So if we take the general population of older adults, combining community dwellers, those who are hospitalized and those who are in nursing home, that average actually comes out to be about 17%. And so in hospitalized patients, it can be up to 40%, and in those in nursing homes, actually up to half of those patients. If we look at the trends over time as well, we will see that that as people age, there's going to be a higher incidence of anemia, and sorry, I should say prevalence. And so you can see that those over the age of 89, that almost 45% of men over the age of 89 will actually have anemia. You'll also see that there's a divergence here between men and women, and we see higher numbers in older men. And that's partly explained by the fact that older men are more likely to have GI cancers, for example, colon cancer or esophageal cancer. And that's associated with the fact that older men are more likely to smoke tobacco and drink alcohol, which are two conditions which can be associated with GI cancers. I hope that with today's talk that you can really appreciate why anemia is so important and why it's important to address this issue, because it can be associated with many conditions, including cardiovascular disease, especially heart failure, cognitive impairment, lower extremity strength, falls, depression, a longer length of stay when they're in the hospital, and also all-cause mortality and cardiovascular mortality. So in this next part of the presentation, I'm just going to walk you through some different studies that have looked into these association, especially for those for geriatric syndromes. So firstly, cognitive impairment. So in the health, aging, and body composition study, this looked at older adults without dementia, and it looked at them over time. And what they actually found is that after 11 years of follow-up, those older adults who had anemia actually had a higher risk of developing dementia compared to those that did not have anemia. And mind you, that hazard ratio is a smaller ratio, but it remained significant even when we controlled for the person's age, their sex, their education level, their race, and their comorbidities. So it seems like anemia independently is associated with dementia in older adults. In the Women's Health and Aging study, they found that women aged 70 to 80 who had mild anemia with a hemoglobin between 10 and 12, compared to women who had a hemoglobin above 12, actually had lower scores on TRAILS A and TRAILS B testing, which is a proxy that we'll often use for executive function in older adults. In terms of depression, the Health and Anemia Observational Study of community-dwelling adults in Italy found that participants who had anemia, as compared to those who did not have anemia, actually had higher geriatric depression score numbers compared to those who did not. And in the Chianti aging study in Tuscany, they found that patients who had anemia were more likely to have depression, even when adjusted for comorbid disease like heart failure, cancers, and chronic kidney disease, or CKD. With anemia and falls, this entity is a little bit harder to study because in a lot of surveys, they tend to rely on self-reported falls. It can be quite hard to measure the actual number of falls when we're looking at older adults. So, excuse me, so in the Cora age study that was done in Germany, they did find a positive association between anemia and self-reported falls in men and women in a 3-year follow-up period. And in the Tromsø 5 study, which looked at community dwelling adults also with self-reported falls, they found that actually when they adjusted their analysis for sex, age, medication use, I believe they looked at if they were on more medications, they didn't find a statistical association between anemia and falls. Looking at anemia and muscle strength and muscle mass, the Chianti aging study found that patients who had anemia had reduced knee extensor strength and decreased hand grip strength, as opposed to those who did not have anemia. And the Kay and Hain study, which is a survey in Korea, found that older males who had anemia were 2.83 times more likely to have low muscle mass. And this survey really took a deep dive into particular variables like how often were they exercising, what was their total caloric intake in a day, did they have chronic diseases. And so they found that even if all come as equal. They exercised the same amounts, they ate the same number of calories, they had the same profile of chronic diseases, that the anemic males were more likely to have low muscle mass. And then for anemia and heart failure, we actually have seen that about 30% of stable outpatient heart failure patients have iron deficiency anemia, and about 1/2 of patients who have heart failure in the hospital will have iron deficiency anemia. And in this large meta-analysis that was done in 2008, they found that in patients who had heart failure, that if they were anemic, they had a double relative risk of mortality. So now that we've talked about why anemia is really important, I just wanted to switch gears and talk a little bit about how we define anemia. So depending on your institution, there may be different cutoffs, but this is just a review that a normal range for a hematocrit in males is going to be between 39 and 50, in women between 35 and 47. And then for a hemoglobin, between 14 to 18 in males and 12 to 16 in women. And depending on the institution, you actually might find that some institutions or some practitioners tend to prefer to track hemoglobin. Other people tend to prefer to track a hematocrit. And this is just a little bit of a nod, just to mention that hemoglobin is an actual measured value, whereas hematocrit is calculated. And so how they calculate hematocrit is that they actually take the total packed red blood cell volume and they spin it down, and then they actually look at the actual composition in a test tube, and there'll be different kind of estimates and different tools that are used, but you can see that if you're kind of doing this particular estimate from a spun red cell volume, that you might not have as much, that you could have actually more variability. So in my general practice, I actually prefer to track a hemoglobin, as I find it to be more accurate. And then looking at the actual definitions of what is anemia. So the World Health Organization, or the WHO, defines anemia as a hemoglobin below 13 in men and a hemoglobin below 12 in women. As we saw in that earlier graph, there's an increased prevalence of anemia in older adults. And so if we know that 89%, if we know that 45% of males over the age of 89 have anemia, why don't we have an age adjustment? And the reason why we don't have that age adjustment is because you technically have to have a cohort of healthy people that you can say that's a normal anemia. But the problem is it's really difficult to pin down a healthy cohort, because people, as they age, they're going to be able to have a new diagnosis of a new disease. And so it's really difficult to define what is healthy and what is normal. And so that's why we don't have an age adjustment for anemia in older adults. Is more likely to have an association between that anemia being associated with a GI malignancy. So if in my general practice, if a patient has a hemoglobin of 10 and I'm seeing them in the clinics, I usually work that up, because I want to definitely make sure that I'm ruling out colon cancer in this person. For other reasons, if your patient is symptomatic from anemia, if they short of breath, if they're feeling dizzy, if they're feeling fatigued, that's a good reason to also work it up. And then if they've had recent blood loss, if they recently had a big spine surgery or hip surgery, or they've recently had trauma and they've lost blood, that's also an important time to be able to work up their anemia, because if they are deficient in iron or B12, for example, we want to be able to make sure that they're repleted so they have the best chance of recovery. And so this is a question for you all. So now that we're going to pivot towards thinking about what is the cause of anemia, this is a true or false. So feel free to enter in the chat. So true or false, one of the top causes of anemia in older adults is unexplained anemia. Just put it in the chat. What do you guys think? I see some trues. Great, yeah, so fantastic, yep. Great job, everyone. So this is a little bit of a leading question, so that's on me. Yes, so you're absolutely right. So based on US-based surveys, approximately 1/3 of anemia in older adults is actually unexplained. Not very satisfying, certainly for me. I just want to take care of my patients. I just want to know, I want to be able to have a plan, but that's the reality. It's actually 1/3. So thinking about the various causes of anemia, they are wide and varied. They can range anywhere from anemia of chronic disease, which we'll talk about a little bit later, nutritional deficiencies, endocrine causes, blood loss, which is obvious. They could be associated with medications. They could be as a result of consumption, which can sometimes be from autoimmune conditions or maybe from mechanical trauma as well. Malignancy, and then, as we mentioned, unexplained anemia. And so the three most common causes of anemia in older adults is anemia of chronic disease, nutritional deficiencies, and unexplained anemia. It's also important to note, though, that actually 30 to 40% of cases of anemia in older adults are multifactorial, which is often why we have to think really broadly as we're seeing these patients and making sure that we're taking good histories and also being able to have a wide approach to our workup. So this slide here just shows a few surveys that have been done in the US, the NHANES, which is a national survey, a survey in Chicago, and then SHC stands for Stanford Health, and this is the VA in Palo Alto. And so these three surveys are a little bit different, but broadly you can see that the blue is the unexplained anemia here. The red is anemia of iron deficiency. And then the green here is anemia of inflammation or anemia of chronic disease, which has a little bit of overlap here with CKD, which is chronic kidney disease, and then a little bit of overlap. And then the orange here is folate deficiency. So if you kind of take a step back and you kind of zoom out, you can see that about 1/3 of cases is unexplained. About 1/3 is from iron or B12 or folate, and then the other 1/3 is with anemia of inflammation. So moving on to iron deficiency anemia, which is something that we will likely experience in our work. So the two top causes of iron deficiency anemia are 1, GI blood losses, and 2, malabsorption. And so it's common that we see GI blood loss in older adults because there is going to be a higher incidence of neoplasms or malignancies in older adults. And on top of that, too, there's this entity called Angiodysplasia, which is in the picture that you see here in the right bottom corner. And so this is almost like a stretching of the inner lining of the GI tract, which can then cause blood vessels to be really fragile. And so sometimes these lesions don't necessarily bleed, but when you add on an NSAID or an anti-inflammatory like a Aleve or an ibuprofen, or you add on aspirin, or you add on an oral anticoagulant like warfarin, then they're going to be more prone to bleeding. And so it's almost the combination of the fact that you're going to be able to see more of these abnormal blood vessels in the GI tract, and then you add the added insult of these medications that our older adults tend to be on for arthritis or for strokes or AFib, that's when you actually are more likely to be able to bring out that bleeding. And then malabsorption, this honestly was a little bit surprising to me, but something that I'm encountering more in my practice as a geriatrician. But actually 1/3 of cases of celiac disease are actually diagnosed in older adults. to me, this is always something which I thought, if you had to be young and have a gluten intolerance to actually have celiacs, but it's actually pretty common. And so if you're, encountering an older adult who has some GI symptoms and they're anemic, it's actually worth looking into this as a cause as well. There's also a higher prevalence of H. pylori infection in older adults, and a lot of older adults have GERD or acid reflux, and so they end up being on proton pump inhibitors like pantoprazole or omeprazole, and that can also impact the absorption of iron in the GI tract. And so here's just a schematic just to be able to kind of walk through. And so it always helps for me to go head to toe when I'm thinking about a patient. So malnutrition is actually a cause of iron deficiency in older adults. And I certainly have encountered older adults in my panel and in the hospital who have food scarcity, who might have more of a tea and toast diet, who live alone and just don't really eat a well-balanced diet. And so remembering not only GI blood losses, but also malnutrition as a cause of iron deficiency. And then looking at the upper GI tract, just thinking about esophagitis or gastritis. Do they have an ulcer? Could they have esophageal cancer? And as we talked about a little bit earlier, to the angiodysplasia or those vessel malformations, which can also cause increased bleeding, especially in the setting of aspirin or NSAIDs. And then moving on to malabsorption. So HP is H. pylori infection. AAG is autoimmune autonomic ganglionopathy. That's a mouthful to say. But that's actually a condition for a lot of older adults who kind of have dysmotility, or they just have kind of delayed absorption in the GI tract of food and nutrients. Celiac disease, inflammatory bowel disease, or certain medications like the proton pump inhibitors. And then moving down to the lower GI tract, things like colon cancer or precancerous lesions like polyps that can also bleed, inflammatory bowel disease as well, hemorrhoids or angiodysplasia as well, those vessel malformations. All right, so moving on to B12 deficiency. So this is also quite prevalent in older adults. Up to 20% of older adults will be deficient in B12. And there are a number of reasons why someone might be deficient in B12 as well. One entity which can happen as we age that is more common is this entity called atrophic gastritis, which is basically almost like the stomach lining just becomes less able to absorb nutrients the way that it used to, especially B12. Medications like metformin that a lot of people are on can actually impair the absorption of B12. And so for my patients who have diabetes and are on metformin, I try to make sure that I'm checking B12 levels often as well. Like iron, acid-reducing medications like the proton pump inhibitors will also impair the absorption of B12 in the stomach. I certainly have a lot of patients too who are vegans, and so they're just not getting B12 in their diet. And then people who have autoimmune conditions like pernicious anemia or vitiligo or thyroid disease, often these autoimmune conditions will run hand in hand, and so that will also impact the absorption of B12. And then finally, H. pylori infection. And so there are a multitude of symptoms of B12 deficiency, and I absolutely appreciate that this can be challenging to pass out, especially in older adults who may have a lot of these conditions like cognitive slowing, like insomnia, like impaired proprioception or weakness, ataxia. And so sometimes this can be hard to really pinpoint. And in some severe cases of B12 deficiency, you may also see psychosis as well. There's also a possible link between B12 deficiency and osteoporotic fractures as well. And then glossitis, as you can see in this picture here, are these linear lesions, which you can see on the tongue. That is a sign of B12 deficiency. I think I've seen that in one patient recently. So always important to do a good oral exam as well. All right, folate deficiency is something that we're hopefully seeing less of. I can probably count on my hand the number of times I've seen it. And this is rare because in the late 1990s, there was a mandate to actually fortify grains, breads, and cereals, and pasta with folate. So lots of foods that we all tend to eat regularly. That being said, for people who have poor food access or just a poor nutritional status in general, they're still at risk of having low folate. People who have alcohol use disorder are also more likely to have low folate as well. Anybody who's at risk of malabsorption, especially those who may have had a gastric bypass, they will be at higher risk. And then if you're on certain medications like methotrexate or sulfasalazine, sometimes people are on these medications for rheumatoid arthritis or psoriasis. This impacts the metabolism of folate, and so they will be at risk of having low folate too. Moving on to anemia of chronic disease. So this is an entity that we typically see in people who have chronic disease. And so examples could include chronic kidney disease, if people have autoimmune conditions, if people are struggling with chronic infections like osteomyelitis or infection of the bones, hepatitis, or even if they have a chronic infection of the skin like a sacral decubitus ulcer, they'll also be at higher risk of having anemia of chronic disease. And this is a slide, it takes a little bit of a deep dive into the science, but just wanted to help kind of explain the part of the multiple insults that actually impacts the production of red blood cells in those who have anemia of chronic disease. So if you have a condition like chronic kidney disease that will lead to chronic inflammation, that leads to the production of inflammatory cytokines. And so with that environment, that will actually cause red blood cells to have a faster turnover and a shortened survival. It will also impact the production of new red blood cells as well. And then on top of that, it's going to cause an increase in the production of hepcidin, which is an acute phase reactant that's produced by the liver. And that will also impair the absorption of iron in the body. So you have all of these different reasons why chronic inflammation can lead to anemia. And so on top of having a chronic disease, there are certain older adults, not all older adults, that will experience this condition that broadly is described as inflammaging. And so there are about 50% of older adults will just have this physiology. And what it means is that they just have a higher inflammatory state in their body. And so they will have increased inflammatory cytokines. They will have uptake of iron that gets trapped into red blood cells that are not healthy and not really able to deliver oxygen around the body. They'll have increased hepcidin, which is that acute phase reactant that is produced by the liver that will impair iron absorption. And they'll have decreased EPO, which is the hormone that stimulates the bone marrow to produce more red blood cells. And this is just a slide that will be important to think about when we're talking about iron repletion a little bit later. And so bear with me, as I know we're doing a lot of physiology right now. But with inflammation, you will have increased production of IL-6, which is one of the inflammatory cytokines. And that will cause hepatocytes in the liver to increase the production of hepcidin, that acute phase reactant. And when hepcidin is high, that will actually impair the absorption of iron in the intestines. And so those individuals who have anemia of chronic disease, they may also have iron deficiency anemia, but their physiology is such that they actually have a really hard time absorbing iron. So we'll talk about this a little bit later in the presentation when we're thinking about treatment approaches and how you actually replete these people. All right. And then finally, that last bucket is unexplained anemia. And so that 1/3 of patients in the United States that likely we're just not really able to find a clear cause. So these are older adults that don't really have that really high inflammatory state like we see with those with anemia chronic disease. So they might not have really high inflammatory labs if you decide to check those. In some of these patients, there seems to be an association with low sex hormones. And so in males, you could have lower testosterone, and women lower estrogen. In some cases, they might actually just have like a borderline B12 deficiency, not really at the point that you need to replete them, but maybe early on. Or they might even have some other etiology that just hadn't been found. So they might have actually been hypothyroid, but they just got put into that bucket because that lab just was not sent. And in some patients, but not all, unexplained anemia could also be a precursor to a hematologic malignancy like a MDS or myelodysplastic disease. All right, so we've gone through all these different causes. It can be very overwhelming because it's like, wow, it could be any of these things, you know, where do I even begin? Do I send $1 million workup? And that can be really, really tough. But as we do with everything, always starting off with a good history, looking into whether a patient has had any GI blood loss. Have they had blood in their stools? Have they had dark stools? Have they had any other changes to their bowel habits, more bloating, more gluten intolerance that makes us think of celiac disease, for example? So doing a good nutritional intake as well, understanding if they have food scarcity, what are they actually eating? Is this more of a tea and toast diet? And then taking a good look at their medications too. Are they on a proton pump inhibitor for GERD? Do they take metformin? Are they on a lot of ibuprofen that they've been taking for their arthritis? And also doing a family history too, which I would say shouldn't only be limited to if they have a family history of colon cancer, but I will often ask too about family history of autoimmune conditions, or even asking them if they have a family history of certain dietary intolerances too. Initial labs that I will usually send if I'm seeing a patient in the clinic who has anemia is getting a full set of iron studies. And so that includes a serum iron, a ferritin, a TIBC, which is a total iron binding capacity, a transferrin, and then with that, sometimes a transferrin saturation will be calculated. I will send a B12 level, just knowing that 20% of older adults can have B12 deficiency. I don't send a folate on everybody just because it's actually, at least in our system, a fairly expensive lab. And so I usually pull the trigger on a folate, especially if the patient has an alcohol use disorder, if they're at risk of malnutrition, or if they have malabsorption. I will absolutely send it then. I usually will send a thyroid as well, a comprehensive metabolic panel to look at their liver and kidney function, which could be associated with chronic disease and impair their absorption as well. And then a reticulocyte count, I don't send in everybody, but a reticulocyte cell is a precursor to a red blood cell. And so how you would interpret that is that if somebody has anemia, then you would expect that the body's natural response is to then churn out more red blood cells, because the body should be really thinking, oh, wow, I don't have enough red blood cells. Am I actually delivering enough oxygen around? Maybe I should produce more red blood cells. And so depending on the cause, sometimes that actual response to increase the number of reticulocytes does not always occur. If I'm concerned that someone maybe has a malignancy, especially if their red blood cells are low, their platelets are low, maybe their white blood cells are low as well, I'll also send a peripheral smear. And then for somebody that I'm concerned about GI blood loss, I will send a fecal occult blood test. Just to take a little bit of a dive into iron studies. So there's a lot of different components of iron studies, and it can be hard to interpret, especially in the setting of older adults who might have an increased amount of inflammation in their body. And so serum iron, if that's low, that will be low in iron deficiency. One of the problems, though, is that serum iron, that actual level, it's going to have a fair bit of variability even throughout the day. So because of that variability, it might not actually be the most reliable measure to just use for your diagnosis. The same thing with ferritin. So ferritin is an acute phase reactant. So if there's inflammation, that could cause an increase in the ferritin level. And so it's really hard to just diagnose iron deficiency on a ferritin level alone, because if it's falsely high from a high state of inflammation, you might be falsely reassured that someone is not iron deficient. That being said, a ferritin below 50 is probable that somebody has iron deficiency anemia. The total iron binding capacity is going to be high in iron deficiency, as is a transferrin. And how I think about that is that if your total body is low in iron, your body's going to want to be able to grab onto more of that iron to be able to produce red blood cells. And so it's going to be hungry for iron, and so that's going to be high. A more reliable measure of iron deficiency in older adults is actually looking at a transferrin saturation. And so what we have found, at least in our practice here locally and also in clinical trials, is that if a transferrin saturation is below 10, that patient is going to be very iron deficient. And so it actually would benefit them to be able to restore their iron stores with IV iron, because it actually could take them a really long time to get their stores up just with the oral iron pills, or they might have other comorbidities that would affect that absorption. And especially in heart failure, there's actually a number of trials out there that have found that a transferrin saturation below 20 is the threshold that you should actually think about, giving IV iron in a heart failure patient. And part of the reason for that is you can think about a heart failure patient who has a lot of volume overload. They've got a lot of edema in the legs. They might have edema, they might have fluid in their lungs. That edema or swelling is also going to be in their GI tract as well. And so heart failure patients are going to have a really hard time absorbing oral iron. So going back to that schematic that we saw earlier, this is just to, again, walk through some of the studies. And so if after you've done your history and you've done a good nutritional intake, you've gotten some history, and you potentially are worried about GI blood loss, in addition to sending a fecal occult blood test, if that comes out as positive, there are a number of different ways to be able to try to identify a source of blood loss. Not only is it appropriate to get a colonoscopy and an endoscopy, but sometimes older adults will also need a gastroscopy or a video capsule endoscopy study, which is really actually like a camera that you swallow, and it actually goes through the small bowel. Because as we were talking a little bit earlier about that angiodysplasia, sometimes people will have angiodysplasia that's in their small bowel, but it won't be in their colon, or you won't find it on a upper endoscopy. So if you have a patient that that has a positive fecal occult blood test and the colonoscopy and the endoscopy is negative, sometimes you do have to escalate further diagnostics to a video capsule study to really look at the small bowel. And then, as we were alluding to a little bit earlier, oral iron is something that we encounter often, but it can actually be quite poorly tolerated in older adults. Common side effects that you may have heard of or even experienced yourself are primarily GI side effects, and it could be anywhere from constipation to diarrhea. People can really go either end of the spectrum. A lot of people have nausea, a lot of people have bloating, and just generalized abdominal discomfort. And then, as you may have seen too, they can have dark stools, which can be confusing if you're also trying to work up for GI blood loss too. And there have been some prior studies that have found that even as high as 1 in 2 older adults will actually fail oral repletion therapy, either because they're having all of these symptoms and they just stop it and they just don't want to take it anymore, or because they just can't absorb the oral iron. Some ways that we can think about improving people's tolerance and absorption is, one, to actually give iron every other day. So you may have seen some literature that's come out just in the last 10 years to actually support that giving iron every other day is actually more likely to maximize absorption. And that's because, thinking back to that prior slide that we were talking about earlier with hepcidin, so that's that acute phase reactant that's in the liver. It's by giving iron every other day, it's almost like we're tricking the liver into thinking that actually, it's almost like we're actually bypassing that impaired absorption. So when hepcidin is high in inflammation, it will impair the absorption of iron. So there've actually been studies that have found that the hepcidin levels will remain low and they won't be high if you give iron every other day. So that's why we tend to do it every other day now. There've also been some people who've tried to give lower dose iron instead of the regular amount of elemental iron. So if you go to your local grocery store and you pick up a bottle of ferrous sulfate 325, that has 65 mgs of elemental iron. So there's been some studies that have looked into why don't we just give less of that and just have them take that longer instead. And so this paper down here by Ramon et al. Actually was looking into that particular plan of actually trying to give 15 milligrams of elemental iron instead of the full 65 that we see in our usual supplements. So this is a question that I get a lot too, posing it to you all. So true or false, feel free to enter in the chat. So oral iron should always be given with vitamin C for absorption. What do you all think? All right. Okay. I'm seeing a lot of trues. Great. Great. Okay. Great. Yeah. This is a tricky one. And Mary Cox says, Shaw, great, yes. So actually, this is a little bit tricky, and I have to say, I don't think I really know what the answer is. So I'm going to put here maybe false. So sorry that I'm not being strong about this answer. So actually, just last year, there was a randomized clinical trial that was done in China that was looking at young women. Okay, so young women, not older adults. And so take this with a grain of salt. So young women with a mean age of 38.3 who had iron deficiency anemia. and it randomized the participants to oral iron alone as opposed to oral iron plus vitamin C. And so they only tracked these people for 3 months, and then they tracked them at the 8-week mark, and they didn't actually find a significant difference between the hemoglobin level and the ferritin between these two groups. But I'm going to show you the graph next, though, because you know, overall, if you look at the graph here, it does still favor that that the folks who had iron plus vitamin C did do better, but it did cross the middle line. So it wasn't a significant difference, which is why I'm hedging a little bit. And so how iron is supposed to help, how vitamin C is supposed to help iron be absorbed into the GI tract is that vitamin C plus iron, it forms a chelated compound. And so that's supposed to help absorption in the small bowel. And so with this data, I would say that probably most likely some vitamin C still helps, especially in older adults who are probably going to be at higher risk of malabsorption. But when I'm thinking about older adults and thinking about their pill burden, thinking about how many medications they're on, if I'm thinking about an older adult who really has a lot of medications, I will, in those cases, I'll probably deprescribe that vitamin D. I'll probably take vitamin C. I'll probably take it off, but I'll just make sure that they're getting good vitamin C through their diet, making sure that they're eating vegetables, making sure that they're eating fruit, because I'm not sure how much additional benefit that extra pill in their pill box is really making. But I'd also say that this particular trial is one of probably the only one that I've seen that actually is a randomized control trial that compares the two. And I'm not really sure how generalizable a study in young women is to our population. So my approach is really, you know, if they're able to get vitamin C through their diet, then maybe we're okay actually without that extra pill. All right, and so talking a little bit more about how we're actually repleting people. And so the divalent forms of oral iron, so the ferrous gluconate or the ferrous sulfates that will come in like a 325, 324, they're actually overall better absorbed in the bloodstream compared to some other oral forms of iron. In general, you need to replete for at least 3 months, but often longer. In my practice, I often see that you need 6 months before you really see a difference. And like we talked about earlier, if people are having side effects, GI side effects, or if at the 3-month point you're not really seeing any difference in the iron in your iron studies, you might actually want to think about giving them an IV infusion instead, especially for your heart failure patient who's going to have a lot of gut edema and they're just not really able to absorb their iron. And then in terms of the IV forms, there are some calculators that are out there, and I'm sure our pharmacy colleagues who are on the call know that you can try to calculate the mean total iron that someone's going to need to replete their stores. But a general rule of thumb is that if somebody has anemia from iron deficiency, they generally need a total of 1 gram of iron to really be able to replete their stores and get those red blood cells churning out again to a normal level. There are many different types of IV iron that are out there. The most common types that you've probably have seen are the iron sucrose or gluconate, which deliver a smaller amount of IV iron, but overall a more affordable and better tolerated, as opposed to some of the other forms like dextran or carboxymaltose, which can actually give about 1 gram at a time. For me, this tends to be quite cost prohibitive. We'll often use this where I am for cancer patients as well. But I'm sure that every institution has different access and also different approaches. And then thinking about B12 deficiency. So again, there's going to be a lot of variability in what the threshold is. Some guidelines say 200, other guidelines say 350. At our institution, we tend to treat B12 when it's below 300. And there's not a lot of high quality randomized controlled trials out there that are comparing B12 pills to IM B12. I often have people ask me, should I do the shots or should I take a pill? And so there's not really great data to compare those head to head. But in general, the oral repletion tends to work well for people who just are not really eating enough B12 in their diet. So you're vegans. If you do start off someone with oral iron, make sure that you check that level again in 3 months to be able to see if they're responding to that. Because if they're not, then maybe you do actually need the IM treatment. And when B12 is severely low, when it's below 100, that's when you should actually be using the IM form, or if they're having neurologic symptoms. If somebody has a history of pernicious anemia, which is an autoimmune condition, or if they're at risk of malabsorption, then the IM formulation is the only type that will actually effectively replete their B12 levels. And if someone is severely low in B12, if they're below 100, the general approach is that you actually give them a shot once a week. And then at the 1 month mark, you want to be able to check their level and see if it's actually normalized. And then if it has from there, then you can then switch to once a month injections. And IM shots for some people is no walk in the park, and a lot of people don't really want to be able to do that, or they just don't have the mechanics to, or they don't have a caregiver who really feels comfortable with that. And so you can also give it subcutaneously as well. And like before, we don't have large studies that compare the subcutaneous form to the IM form. But what we do know from smaller trials is that giving B12 either subcutaneously or IM is probably equivalent. They haven't seen really big differences in smaller trials. So it's probably okay to give it a B12 shot in the belly if that's easier for the patient. And like before, making sure that you check the levels every 3 months just to make sure that people have adequate repletion. And if they're stable enough, then I'd say you could probably space that out to 6 to 12 months thereafter. And then I just wanted to spend the last part of today's presentation just with a brief nod to blood transfusions. This is a topic which is really confusing to me, especially on the inpatient side when I'm taking care of hip fracture patients who have lost blood and have had surgery. And I would say that overall practices regarding blood transfusion have really changed over the last 10 years. So I think that I would just say that this is kind of an area that I think is changing a lot, and there's still going to be different practices depending on your institution. So one important trial that was done about 10 years ago looked at older adults who had cardiovascular risk factors, who had hip surgery. And so they randomized these people to receiving blood to reach a target hemoglobin of 10 as opposed to a hemoglobin of 8. And the hypothesis was, if we know that anemia can cause symptoms, if we know that it's related with muscle strength, why not give people more blood? You know, is that going to help to improve their recovery? And so the functional measure that they used in this trial was to see if they could actually walk independently 10 feet without assistance 60 days afterwards. And they found that in these two groups, the people who got more blood compared to the people who did not, that they actually didn't find a difference in mortality or this proxy for functional status. The other thing which I wanted to remark on is that I was always taught in my training, so if someone's having a heart attack, you need to make sure that they're getting lots of blood because they need to be able to get enough blood flow to those ischemic vessels. And so if someone's having a heart attack, then we have to give them more blood. And this is actually slowly being debunked as well. So this trial from 2020 actually looked at patients who were having acute myocardial ischemia, so like an acute heart attack. And they actually found that in the group that was getting more blood, a hemoglobin to 10, as opposed to those targeting a hemoglobin of 8, that there was actually no difference in the mortality rate if they weren't more likely to have another heart attack if they were anemic, and that actually those who were getting more blood were more likely to experience infections after their heart attack and acute lung injury. So I hope you're able to see that the way that we approach blood transfusion is really changing with more studies that we're doing. But the exact threshold of what we should be transfusing people is still a little bit hazy to me, since some of these trials were using a target hemoglobin of 7, some were using a target hemoglobin of 8. And so there's not a lot of trials that are really comparing a hemoglobin of 7 to a hemoglobin of 8, just because there's not a whole lot of clinical difference between those. And so my general rule of thumb is that a transfusion threshold of about 7 to 8 in an older adult is appropriate. But certainly you should be transfusing if they're symptomatic, if they're feeling dizzy, if they're feeling short of breath. And just to appreciate that there can be a lot of side effects to blood transfusions, like the lung injury, like infection, like heart failure exacerbations as well.
Ruru, we had a question a couple of slides back, if you don't mind.
Yeah.
Kristen mentioned that her blind mother had a bad duodenal bleed, but couldn't see the results. When entering the hospital, her H&H looked okay due to excessive fluid loss. So the hematocrit would not work in that situation, she thinks.
Yeah, that's a great point that you brought up, Kristen. And I think that I agree that it's potentially that the hematocrit is not as accurate. The other thing too that I have noticed is that sometimes in people who are having GI bleeding, that there can sometimes be a little bit of a lag between the blood, between the actual lab value and between what is actually going on. And so if someone is having an acute bleed and they're losing a lot of blood and you happen to get that one particular snapshot in time, there's still active bleeding which can be going on. And so absolutely, I agree that the hematocrit is less accurate, but I'd also say that there's sometimes a little bit of a lag in terms of what you actually see. But yeah, great point. So I'm just going to use the remaining time just to quickly go through a practice case, but I'm also happy just to hold off from this if there are more questions, because I definitely want to be able to make sure that we have more time. So I can take a pause now if anybody has any pressing questions, or I'm happy to go through a case and we can talk a little bit more after that. Feel free to put in the chat if you have anything that you strongly prefer.
I think if we get started on the case, some questions may come up and we can sequence them.
Okay, sounds good. Thanks, Bob. All right, so I'm going to go through a case that is loosely based on some patients that I have seen in clinic. And so I have a 78-year-old community dwelling male who has hypertension, hypothyroidism, colonic polyps, who I just saw recently for a wellness visit. And I just got some routine labs, like a comprehensive metabolic panel. I got a CBC just because I hadn't gotten one in a year. And I saw that his hemoglobin was 11.7 and his creatinine was 1.1. So if you're seeing this patient in your clinic, what would you do next, just in terms of history history in terms of labs. What would you like to send? Just feel free to throw it in the chat. Any particular things that you would want to know in his history, or any particular labs you'd want to get? Kristen says a colonoscopy. That's a great point. Especially with that history of colonic polyps, you know, that he's got a potentially pre-malignant cause. Great, and history of bleeding from Nancy, great. Yep, so making sure that we're asking about dark stools, any bright red blood. What about labs? And any labs that you'd all want to send? I know we just talked about a lot of labs, so that's okay. So I'll show you. I'll show you what I did with this patient, knowing that this is my one approach, and this is going to be something that other people do differently. Great. Kristen says a B12. Great. Yeah. And yeah, the reason why actually a B12 would be helpful is he has hypothyroidism, and often autoimmune conditions will run in families. And so somebody who has thyroid disease is actually maybe more likely to have pernicious anemia, which is an autoimmune condition. Heather says a PT-INR. Great. So trying to figure out, you know, is there like an issue with, like, does he have a hypercoagulable state? That's a good one. Great. Anybody else have anything else that they would want? All right, well, I'll show you what I did for this patient and kind of walk through some of his labs. So for this particular patient, I wanted to take a good history. So I asked him about history of GI bleeding. You know, has he had dark stools? Has he had a bright red blood? Does he have hemorrhoids? Has he had pain with defecation? Does he have and any other cause there. I try to do a good nutritional history as well. So asking him about his diet, asking him if he's had any changes to his bowel habits, making sure that I'm not missing celiac disease as well, since he seems to be kind of like a autoimmune guy. I also made sure that I did a good family history too. And he does have a family history of colon cancer that I learned through that. And then looking at his medications, I wanted to take a look and make sure that he's not on any medications that would make him more prone to bleeding. And so he wasn't on aspirin, he wasn't taking any non-steroidal anti-inflammatories, he's not on an anticoagulant, he's not taking metformin or a proton pump inhibitor, anything else that would impact his absorption. Did a good exam as well, didn't see any abnormalities on a rectal exam. It didn't seem like he had anything else on his exam that was a change from prior. And he didn't really have the pale kind of mucous membranes too that we see in people who have more significant iron deficiency anemia. And the initial labs that I sent on him, I sent some iron studies, I sent a TSH since he's got hypothyroidism, I also sent a B12, I sent a fecal occult blood test just to be able to see is he losing any blood, and I also sent a reticulocyte count just to see is his actual body responding to that depletion of blood, is his red blood cell production actually getting kicked up. And so these were his labs. So his serum iron was 70, which is for us kind of in the low normal range. His total iron binding capacity was 295. His ferritin was low at 21. His transferrin saturation was 25%. He had a normal thyroid, a normal B12 level. His reticulocyte count was a little bit low, but grossly normal. And his fecal occult blood test was actually negative. That being said, I still did refer him for a colonoscopy, especially because he has this history of colonic polyps. And so the tricky thing with fecal occult blood tests is that kind of depending on when you actually get them, sometimes they'll still be negative, but if somebody still has a risk factor for GI bleeding, so for him, the history of colonic polyps and also the fact that he's got a family history of colon cancer, that kind of pushed me more towards making sure that he got another colonoscopy. I did start him on some oral iron every other day, knowing that he's got some slight renal impairment, and so probably some amount of inflammation. And so knowing that he may or may not actually properly respond to that. And so he was willing to take it. He hasn't really had any GI upset from it yet. And so we're kind of just plowing through. But I will plan to repeat the CBC and repeat the iron studies in 3 months, just to make sure that he's adequately absorbing that iron. And if it seems like he's not, then I'll make sure that we think about IV iron after that. And obviously I still have to check in and see what the results of his colonoscopy is too. So with that, just in summary, I hope that you've been able to recognize that anemia is associated with many geriatric syndromes, including cognitive impairment, decreased muscle strength, depression, and heart failure. I hope you're able to appreciate that while it seems like a lot of older adults have anemia, that in community dwelling adults, it's really only about 10%, and that a hemoglobin below 10 should always be evaluated to make sure that you're not missing an occult GI malignancy. Hope you're able to appreciate that there are many causes of anemia, but the most common causes in older adults are iron deficiency and B12 deficiency, anemia of chronic disease, and unexplained anemia, and also acknowledging that 30 to 40% of cases are multifactorial, which is why we have to cast a wide net when we're thinking about these patients. And then PO iron should be given every other day to be able to maximize absorption, and that you may not actually need vitamin C, especially if you're thinking about deprescribing. And to think about IV iron, especially for people who aren't responding to oral iron, who are having GI side effects, and especially for patients who have heart failure, who are going to have more gut edema. All right, so that's about it from my presentation. Thank you all for your attention and for letting me gab on for so long. This is a really big topic, and I appreciate all of you being here and participating in the questions. And thank you for your kind words, Kristen.
So, Ruru, I actually have just what may seem a silly general question, but I get asked a lot by patients. If you have a ready response when they ask about iron fortified foods, like cereals, for preventing or treating iron deficiency anemia.
Yeah, actually, I haven't encountered that too much myself, Bob, but I often have people ask me, hey, I just take a regular multivitamin that has iron. Why do I need to take that dang vitamin supplementation? Why can't I just eat my fortified food or my iron pill? And so I would say have a look at the label of the food or the Centrum multivitamin that your patient is on, and actually look at how much elemental iron there is in that. My guess is it's probably not as much as there is in like a regular ferrous sulfate that has the 65 milligrams of elemental iron. Knowing that people hate those iron pills, I think that if their iron deficiency isn't really that significant, then you could probably get away with just that fortified food or that multivitamin, but just knowing that it's probably going to take more than the 3 months or more than the 6 months that you would expect for those iron levels to really go up. And so, you know, like everything, I think there's just a little bit of give or take that we have with our patients. And so if that's the only way that they're willing to take iron and their iron deficiency isn't really significant, then I'd say let's go for it, but let's just make sure that we check labs within a year just to make sure that things are moving in the right direction. That was a very long-winded answer.
No, but I appreciate it. And this has just been a great presentation because it's been very comprehensive and yet, you know, very relevant to different providers at different, you know, areas of care and levels of care. So I really appreciate that.
Oh, yeah, of course.
Other questions from anyone? All right, I think we're going to conclude. Ruru, I'm wondering if I can just give you a quick phone call on your cell phone to check a couple of things. If there are other questions, we will end the meeting and I will see you next week. And thank you so much, Dr. Wang. This was just excellent, really helpful. It'll become a great resource. Thank you.
Thank you, Bob. Thank you, everyone. Thank you for having me.